Hello, and welcome to the Governor's Virtual Housing and Economic Development Conference. We are delighted to be here with you today. My name is Micheline Davis. I am the President and CEO of National Medical Fellowships Incorporated, an organization that has been around since 1946, advancing health equity and eliminating healthcare disparities by ensuring a pipeline of diversity that is underrepresented in medicine. For the last 75 years, NMF has literally been providing over $40 million to some 32,000 alumni. We are the reason why there are so many clinicians of color in the continental United States. I'm delighted to be able to serve as your moderator on today. And today we're going to be talking about the importance of addressing minority health disparities when undertaking community development efforts. I'm delighted to be joined by two incredible panelists. Marcela Espina Maziers is the Deputy Commissioner of Health Systems of the New Jersey Department of Health, and Dr. Chris T. Purnell, who is the Chief Strategic Integration and Health Equity Officer at University Hospital.
And it's a pleasure to be here with this esteemed panel, Dr. Chris Purnell and Micheline. Thank you for giving me the opportunity to speak a little bit about what we've seen here in the state of New Jersey. My name is Marcela Espina Maziers. I am the Deputy Commissioner for Health Systems for the Department of Health. I oversee the licensing, inspections, and regulatory processes for all of our licensed healthcare facilities in the state of New Jersey, including the certificate of need. And I'll get to a little bit more info on that as we speak. Thank you for having me.
Thank you. Dr. Chris, please.
Thank you, Micheline. Dr. Chris Purnell, I'm here at University Hospital, Chief Strategic Integration and Health Equity Officer. I am a public health and preventive medicine physician by training. In this role, this office oversees population health, community affairs, strategic planning, the patient and human experience, and is responsible for the hospital's first ever launch of a comprehensive equity and inclusion strategy. I like to tell people the work that I do, it's not hard work, it is heart work, and that we have been living in actually a very tumultuous time, but is a time that has refocused and hopefully reshaped our priorities, not just as institutions or systems, but as a nation. So very, very happy to be here and to have this conversation.
Thank you. Ladies and gentlemen, I want you to sit back and get ready. We are going to actually have the Deputy Commissioner begin to set the stage for us so that we can ensure that we are all having one conversation. We do not want you to sit on the sidelines in any way. You see, it is your health that literally hangs in the Delta. We know that improved housing and community development conditions can save lives, prevent disease, increase quality of life, reduce poverty, and help mitigate climate change. Housing and community development are becoming increasingly important to health in light of urban growth, aging populations, and environmental injustice. With that, I turn to our Deputy Commissioner Marcela, so that she might be able to talk to us for a moment, not about just what it is to literally need to ensure that we are living healthier and actually pushing back healthcare disparities, but what actually took place in the state of New Jersey as COVID-19 began to really be rampant through our communities. Many of us saw the decimation of COVID. So what was indeed the response? How are we still navigating these rough and choppy waters as new variants like Delta, Delta Plus, Lambda, now Mu? How are we literally preparing ourselves to be able to adapt to this new normal? With that, Deputy Commissioner.
Thank you so much for that. I want to give a little bit of an overview of the data that we've gathered, showing you how the impact in the state of New Jersey has been, in particular, so hard on our communities of color, of the disparate impact that we've had in locations where access to healthcare is not immediate. And also want to highlight that this is going to be a disease that will be with us for a long time. And there aren't a lot of options for us as far as what can we do immediately I want to just talk a little bit about the numbers and what we saw in the state of New Jersey. As you know, the state of New Jersey got hit hard and fast. We reached our capacity in hospitals in 2020. By the middle of April, we had over 8,000 people in ICUs. Our number of beds that had to be added to respond to that was double in order to take in all of the individuals that at that time, this was an incredibly novel virus to us when it impacted the state of New Jersey. At that time, we had very little knowledge of transmissibility. Testing was incredibly scarce, and the same with personal protective equipment or PPE. So let's just go through some of the numbers of what we saw in the state. This is the racial breakdown of the COVID-19 impact in the state of New Jersey. The gray bar shows you the proportion of the state population for each of the categories. So the state of New Jersey, Black alone, not Hispanic, the composition of that population is 13%. Of the 13%, we had 12% of all of the COVID-19 cases be in Black non-Hispanic individuals. Hospitalizations were 22% for Black Hispanic individuals. And the COVID-19 deaths, as you know, were 16%. So even though the racial makeup is only 13% for the state of New Jersey, overwhelmingly, Black and Hispanic individuals were the ones that were hospitalized, had cases of COVID, and died. For the Hispanic and Latino, 21%, they make up 21% of the population in the state of New Jersey. The proportion of cases was 24%, 26% of all hospitalizations, and 19% of all COVID deaths. And then you could compare that to the Asian population and the white population. In the beginning of the pandemic, what we saw was the impact that this disease had on hospitalizations and deaths on individuals that were 65 years of age and older. Right here, you could already see that there are disparities in the longevity for individuals of color in the state of New Jersey. We have more white non-Hispanic individuals that live longer. And so the impact of that of the cases on these individuals was vast, and it was fast as far as when most of the deaths occurred in the state and the hospitalizations. The proportion of the population is 55% for white non-Hispanic, and we saw 42% of the cases and 35% of hospitalizations be in this category, and 55% of all the deaths. The majority of those deaths were in individuals 65 and older. Of course, now we have a very powerful tool, which is vaccination. The rates of vaccination have been slowly increasing. It has been hard to get to communities that have no primary care physicians, communities that may only have a pharmacy that may not even be carrying all of the vaccines or have the hours for individuals to be vaccinated. For white alone, not Hispanic, we have 47% of the population now have received a dose of a vaccine. For the Black population, only 8%. For the Hispanic population, 17% of them, 10% for Asian. And of course, the other category may have in it some of the individuals from our Black and Hispanic community. But these are the rates of vaccination as of yesterday. So we had currently the number of counties that have a gap of more than 20,000 to get to 70% vaccination. We wanted to get to 70% vaccination to have the most protection in every one of the communities. As you can imagine, those 11 municipalities also correlate to our municipalities with the highest index of vulnerability, urban centers, poverty and inequities in healthcare. The total number of vaccinations that were needed to reach 70% across all municipalities in New Jersey was 343,000. And we have 29 municipalities that were below 70% for those 18 plus. So 66% overall coverage in New Jersey for first dose for 18 plus, that's where we are at the moment. So we had to select some of these municipalities to do targeted approaches, and we'll talk a little bit about that. Just wanted to leave you with that. I will talk a little bit about the increase in vaccination in these high-risk communities and how we had to develop culturally competent communication to get to them and think outside the box on how to reach these individuals and bring them to pop-up events to reach them because they had no access in their communities to a pharmacy, to a hospital, or to primary care doctors that were giving vaccines. So what we have achieved since the inception of this targeted program to our hard to reach communities is that we now are down to 3 counties that have a much smaller gap to get to that 70% coverage. 62,000 vaccinations to reach that 70% we're giving across all municipalities. And the total number of initial municipalities that are below 70% vaccinated has now dropped to 4. So now the state of New Jersey is at 82% coverage in vaccination for first dose for all the adults 18 plus in all categories. So with that, I just want to move, I could leave this slide up and we could talk a little bit and come back to this. These are the populations that we targeted that have now reached that 70%. And as you could see, we still have some stragglers towards the bottom of the screen. Those are the ones where adults haven't reached that 70% of protection with vaccination. Irvington Township in Essex County, Camden City in Camden, East Orange City in Essex, and Lakewood Township in Ocean. The rest of the municipalities have reached to 70. We are now striving to get them over 70% to 85% actually. So it can be done. It just takes a lot of work. And I think that that's part of what we want to discuss today. Why do it took us much longer to get to these municipalities? What are the things that we have to do to make sure that there's resiliency and coverage and availability of this life-saving vaccination for these communities?
Thank you so much, Marcela. That was a fantastic overview. You really helped to set the table around really how New Jersey both was hit by and then responded to the COVID-19 pandemic. I know that it goes without saying, I speak for many of us when we say thank you. Thank you for your dedication and sacrifice in serving in public service in order to ensure that populations and communities made vulnerable as a result of systemic and structural inequity that we continue to literally have an opportunity to fight back against this virus. It has long been understood that many factors beyond healthcare actually influence health. That social and economic determinants of health include income, education, physical environment, social isolation, concentration of poverty. Given this reality, there's a growing realization of the potential for synergies between work to revitalize lots of low-income communities and the need to promote and improve health and health equity. Community development encompasses a range of efforts to improve the physical, economic, and social environment by promoting affordable housing, small business development, job creation, and social cohesion in neighborhoods made vulnerable. And while the field of economic and community development is diverse, it does include real estate developers, financial institutions, and other investors, community organizations, and even local governments. All of these players have really unique assets as well as a network of connections that can be used to address the root causes that affect health outcomes. With that, I'd love to turn to the good doctor. We heard so much through the Deputy Commissioner's presentation about really the rate of vaccination in so many of these areas, and then quite frankly, in some of the most vulnerable, what the need is there and how it still exists. Can you share with us a little bit of context around why it is that particular communities might very well have hesitancy about adopting the vaccine?
Thank you, Micheline, and thank you, Deputy Commissioner. If I can, let me first start with the premise of why disparities occur, right? Disparities are known to occur if you look in the literature, and to quote one of those pantheons from the literature, Dr. Cameron Jones, because of differential access to care, because of differential access in the quality of care received, and because of differential access to life opportunities. So what we know is that whether you say political determinants, structural determinants, or social determinants of health, there are foundational community factors that drive health and well-being. Because of that milieu, we saw earthquakes of devastation. We saw earthquakes of devastation that were the results of the collision of multiple pandemics, the collision of the pandemic of systemic racism and the pandemic of coronavirus. That's why we saw the inequities exposed, right? Disparities are the result of inequities. We saw those inequities just exposed and laid bare before our cities, before our state, and even before our nation and this world. And so it's very important for us to start there. Whenever there is a public health crisis, whenever there is an economic crisis, whenever there is a public health disaster, communities, Black and Brown communities, communities who have been historically stigmatized and excluded, fare disproportionately worse because of their histories, because of contemporary injustices, and because of designs of systems that distribute resources in a disparate and unjust and unfair way. We have to use that language. Conversations about health equity are fundamentally conversations about health justice, are fundamentally conversations around racial justice. So if we have that understanding, and then we begin to say, well, why do we see differential rates of vaccination in the communities across New Jersey, especially race by race and ethnicity? There are a host of factors, Micheline, and those factors, again, have to start with root issues, have to start within the soil, has to start with conversations around systemic and structural racism. If I go back to that pantheon that I was describing, Dr. Cameron Jones, she defines racism as a system of structuring opportunity, whereby one group based on their skin color or phenotype is disadvantaged, whereby another group based on their skin color or phenotype is advantaged, but the strength of the society as a whole is sapped. The society as a whole is sapped. So as long as our Black and Brown communities are suffering, we are all suffering. And because of those historical factors, because of those systemic factors, access to resources, access to living wage, access to affordable and quality housing, access to clean air, to be able to walk and to recreate without toxic and traumatic levels of community violence. All of those issues contribute to the choice or the decision to get vaccinated. And it's not divorced from it. It is intimately and intricately woven together. And I think about my own family, right? I think about the fact that I lost my father during this pandemic. So what the Deputy Commissioner is describing, I experienced working in University Hospital, right? Being at the epicenter of the surge back in the spring of 2020, seeing every bed, nearly every bed in this institution filled with a patient struggling with or succumbing to coronavirus, that being disproportionately Black and Brown faces. 4 miles away from me, my father was dying in another hospital because he had the same structural determinants, the same social and political determinants that shaped his life. And so unless we deal with that, we can't begin to have a conversation with people around the choice to get vaccinated, because that choice to get vaccinated is not separate from their contemporary experiences in healthcare. It is not separate from historical experiences in healthcare. It is not separate from issues around access. How convenient are there transportation barriers? Are there time barriers? Are there cost barriers? And so often we talk about how the vaccine is free, but there are still costs associated with vaccination. And so it is within that framework that we have to focus purposefully on those upstream factors so that we can not only understand and then untangle the web of inequities that lead to this disparities, but then we can give people culturally responsive, culturally competent, culturally tailored, or as I like to say, culturally and socially fluent health systems to meet those needs. And one of the last things I will say is, again, another pantheon in the field, speaking about the Dean Dana, who wrote Just Medicine. And she says that hospitals should be hubs of racial healing. Yes. The only way for hospitals and health systems to be hubs of racial healing is to fully actualize the mandate as an anchor institution. What does that mean? How is a hospital spurring the local economy? How is a hospital developing or offering opportunity around hiring in that community or region? How is a hospital procuring services? How is a hospital making stands around issues like systemic racism? What are the actions? What are the policies? Not just from the aspect of inward facing in the institution, but as that anchor, what are they doing to build that web of equity, access, and justice? So that's the framework that we have to live in order to understand how to prevent earthquakes of devastation, in order to how to meet people where they are and explain the benefits of vaccination, and then for all of us to get to the other side.
I love it. So two things. One, amen and hallelujah, right? So the reason why I wanted to ask the question of you is in order to set the contextual understanding of the impact and effect of historical systemic inequity, structural systemic racism. Listen, I tend to not leave individual racism off the table because it's been the racism of the individuals who have been in control of the systems and the structures that help to bring us to where we are today, right? So I love exactly the way in which you've laid it out for folks and really helped to bring it along. Deputy Commissioner, you say what to that? The good
Absolutely.
doctor mentioned Just Medicine by Dana Bowen-Maxwell, who I absolutely adore and had the opportunity.
The Dean is phenomenal.
Yes, I had the opportunity to work with her. She's incredible. And as a result of that, one of the issues that you laid out so eloquently, so articulately, Dr. Chris, is the fact that, hospitals should be hubs of healing, right? But one of the issues there is even in the acknowledgement of systemically, historically, how often they've contributed to the proliferation of structural and systemic racism, right? And so, Deputy Commissioner, I turn to you now, Marcela, in order to talk to us about what some of the things that the department really is doing in order to help usher that along, and to comment on the good doctor's comments.
So I think that since the start of this administration under Governor Murphy, the department, and in my role overseeing all of the statutory and regulatory processes that govern the way that healthcare is delivered in the state of New Jersey, as far as the facilities, the hospitals, the ambulatory surgical centers, et cetera, what we've had in mind with every decision that we make is looking at what has been set up. What systemic racism is embedded into our regulatory processes that is keeping communities of color from receiving the care that they need in their communities. And when this pandemic hit, we saw with clear demonstration of what happens when you have the lowest investment in public health. When you have anchor institutions that should be anchor institutions that have been awarded a certificate of need. The certificate of need process is what we have to go through to award a hospital a license. And that is to meet the needs of that community. That is why you can't just put a hospital wherever you want and you have to go through the certificate of need process. We have to demonstrate that there's a need in that community for that service. And what we saw was that there were some good actors and some not so great actors. And we wanted to look through the lens of what can we do as the regulators to make sure that we propel access? So at the beginning of the pandemic, a lot of those rules that may have kept from hospitals being able to be more out there in the community, we waived, because we understood that at this time, it was kind of like a snowball. We were working towards that, but we had to put the accelerator on some of these decisions in order to bring the care to the communities right where they need it, because it wasn't happening in four walls in a hospital, right? That's not all that we need to do. Or in the investment in public health, the state of New Jersey has the lowest investment in public health of all of the states out of 50 states. What happens? What does that look like? So what that looks like is that you have a public health department, a local health department in your town that had no nurses, no contact tracers, no supplies, no ability to connect, no ability to know in their own municipality who was exhibiting symptoms of COVID and may need monitoring, and then access to treatment. And when something hits where it's novel, those that investment in public health is the first thing that shows that you haven't invested, because there was no way to respond quickly.
That in and of itself almost gives the ability just to stand out in the universe and just have us say nothing after that, right? But one of the things, and the good doctor said this as well, that I've been saying was that even when we heard a top official from a neighboring state indicate that COVID was going to be the great equalizer, those of us who are been in health equity for some time understood that it was not. We understood that it was going to be the great magnifier, that it was going to magnify the fault lines in our society, the fault lines that have intentionally, quite frankly, been created as a result of laws and systems and regulations and rules, right? That help to increase and create the proliferation of the permanence of an underclass, right? For many people, good health is nearly impossible to achieve. The burden of poor health, from preventable chronic conditions to diseases of despair, falls disproportionately on populations of color, on children, on families with low income, and on individuals with a low level of education. Health disparities between systemically oppressed populations and groups at the top of the social ladder persist, and in some cases are indeed widening. And yet decades of research and intervention have resulted in very limited success in reducing health inequities in the United States. Dr. Chris, talk to us for a moment about what needs to be done, what needs to be changed about these approaches in order to actually begin to turn the ship towards, right, better health outcomes for all.
Definitely. So let's go back to the context that the disparities that we see are because of differential access to care, differential access in the quality of care received, and differential access to life exposures and opportunities. And let's start with that last one. So we're not going to begin to solve for equity and justice until we have a fundamental understanding that equity is not equality, that equity is rooted in need, that you must design to need. The greater the deficit, the more robust the intervention must be, the more aggressive the intervention must be, and the more prioritization that the community or population must have, right? And so we need a very fulsome assault on inequity. And that assault has to look at those community foundations of health. It has to look at where people live. Do they have access to affordable and quality housing? And people listening may say, but why? If you begin to look in the literature around why we saw the disproportionate impact of COVID-19 on Black and Brown communities, there are systemic factors that come to the foreground. What we know is that those people who were disproportionately impacted usually lived in homes that were high contact. What is a high contact household? You lived in a crowded or cramped dwelling. It is a dwelling of multiple generations, such that if one person gets exposed, everybody in the household is exposed, because you're not able to appropriately quarantine, or if you're infected, you're not able to appropriately isolate. We know that those same people not only lived in high contact households, but they worked in jobs that were high contact. What does that mean? They either worked on the front lines of the economy, or they worked on the front lines of care. Black and Brown people over-proliferate in service industries. And because we over-proliferate in service industries, we tend to have work jobs that they could not work remotely. They work jobs that they did not have income protections, so they could not take time off from work. So it was an economic choice to show up for work. And because it was an economic choice to show up for work, you work in where you either have direct exposure to the public or close confines, thereby your risk goes up higher. And then again, you have the saddled and burdened history of comorbidities, which don't just hatch out of nowhere. Look, I lost my dad, as you all know. My father had chronic HIV/AIDS infection. My father had severe emphysema. My father had end-stage lymphoma. And those things didn't happen to him in isolation, because he was also a Black man of a certain socioeconomic status, but yet he still was saddled with all of those comorbidities. Okay.
And Chris, as you're talking about this, I just want to add, when the COVID pandemic started here in New Jersey, what was the hardest hit place? It was our congregate settings, our long-term facilities. Who are our CNAs? Our CNAs are predominantly women that are brown and Black.
Definitely.
Women dying. You cannot do that job remotely. And it was a choice of abandon my patients, abandon those residents, and have no food on the table. They were being exposed. They didn't have the right appropriate training, protective equipment.
Right.
Those disparities then hitting those women, they were the ones that died, that were in the hospital.
Definitely. And the last point that I want to make to bring that home, what you're also describing, is that yes, high contact households, yes, high contact front lines of economy and front lines of care. Those same routes use transportation, public transportation, mass transit. So again, risk of exposure is higher. And not only are those groups saddled with more health comorbidities, but those groups have had poor experiences with the health system. Right? Have not had meaningful interactions or meaningful engagements. Look, I am a physician, but I am also a daughter. I will never forget sitting in the emergency room with my mother, who died to severe Parkinson's after she had fallen out of a wheelchair at an acute rehab facility one night, got rushed in, and a physician walks in before he even examines my mother. He tells the nurse, okay, stop what you're doing. Don't hang an IV. She's going back. There's nothing wrong with her. He hadn't even examined her. He just knew there was nothing wrong with her, though she was writhing in pain. Ultimately, my mother was found to have a splenic artery aneurysm, a ticking time bomb in her belly that waited in her belly for weeks and then began to leak blood. That's what I'm describing. When you have those types of experiences, you have to have awareness of that as a system, because when you ask someone to vaccinate, you need to know what's happened to them before.
That's exactly right.
If you touch the stove and it's hot and it's burned you multiple times, you don't want to touch the stove anymore, right? And that's why we at University Hospital, we're looking to have an equity and inclusion strategy that implicates all of those different levers and rungs. And one example of that, we talk about housing, is a partnership that we have with the Housing and Mortgage Finance Agency and a local developer, L&M, to develop an affordable housing development that has supportive housing units, that has a healthcare center at its ground floor, as a way to say where you live is just as important as the access to care that you receive.
Absolutely.
I absolutely love it. And Dr. Chris, as you talk, I cannot help but be reminded of a time when I went with my father. And if you've known me for 5 minutes or for 15 years, everyone knows I am the biggest daddy's girl in the world. The late Bishop has now gone on. But I will tell you, I went with him to a doctor's appointment. and it was for a physical. And I distinctly recall the fact that we entered the room, we waited for the doctor to arrive. The doctor entered by another door, sat down across the room, asked a few questions, and then concluded the appointment. I've never seen a physical given without ever touching the patient, right? And the tone and tenor of my father's caricature for the rest of the day, right? Just how that weathered him. So when we talk about the weathering of racism, it's the fact that there is the consistency, right? It is the constant of having to deal with issues like that, like what you explained about your mother, like what I'm certain your father went through on a near daily basis, right? It's the weathering of all of that over the term of a life. And then having to turn around and have people say, well, why would we ever lie to you? Of course, this is a safe thing, right? And it really requires a certain level of acknowledgement. One of the things I've been concerned about is the lack of healthcare's ability, right, and demonstrated capacity for acknowledging what has happened. The AMA issued a apology in past years, and certainly under Dr. Maybank, they're doing a great deal in order to deal with this. I had the pleasure of speaking with her just this week. And I love the fact that they're going to dig in deep. Independent hospitals don't necessarily do that, right? And so it's really keenly important that as we frame our community efforts, that we're doing so through a lens which recognizes the historical contribution to disenfranchisement that medicine has brought. Right?
Definitely.
Deputy Commissioner, you mentioned in your presentation at the top of our time together about the non-traditional, right, culturally competent ways in which you really try to make outreach efforts to community members, right? I'd love for you to respond to this conversation with Dr. Chris and talk and then add in a little bit about that effort yet again.
So first and foremost, here I am sitting with these two wonderful women, brown and black. We're talking about our own experiences. I'm sitting here as a deputy commissioner, first Latina to be a deputy commissioner for the Department of Health, overseeing licensing and regulatory processes for our healthcare facilities. I can't divorce that from my experience in the healthcare system in the state of New Jersey. I experienced severe comorbidities after having my first child in a hospital in the state of New Jersey. That continue to impact my daily life to this day, and this was 11 years ago. And I experienced coming into the hospital and to my checkup after having my son and being told, we don't believe that this happened to you. I had a fracture after delivering him. And here was the MRI and the X-ray showing the fracture, and the doctor looking at it and saying, I don't think that this is right. I couldn't walk, but there was absolutely no acknowledgement that the truth was looking at them in a report. But no, that's exaggeration from this patient. So sitting here now, I can't divorce that experience from what I think that needs to be done and what we've pushed for in this administration, and I've pushed for as a deputy commissioner. How do we acknowledge that? The system is broken. How can we at least start bringing back that structural racism and tearing that apart and peeling that away from the everyday experiences, not just maternal mortality and morbidity, but now the morbidities that we see with a pandemic that, as you said, this is the great magnifier of what we saw. So for example, I want to talk to you about the city of Trenton. When we started our vaccination campaigns, of course, the vaccination that was available, the vaccines that were available were very scarce. So the CDC and the FDA started with very prescriptive categories of who could receive those vaccines. Not until April, May this year did we start having enough vaccination where we could actually get rid of the categories and just start vaccinating everybody. When we started in the city of Trenton, we had 40 to 42% of the adults that were eligible vaccinated. So we decided we have to be more proactive. How do we get to these individuals? Press releases and communications from up here are not enough. So we set up an event, first ever, for a Department of Health to actually go out into the community. We're now in a new building. We're more towards the center of the city, walking access. We set up our first vaccination pop-up event in our parking lot. And people just started flooding in, saying, I've never seen this. You're coming here to offer this to us? And you're going to talk to us about the side effects. And we brought some of our nurses and the doctors that work here with us to have those conversations. But more importantly, we walked through every street near us, letting all of our neighbors know, we're the Department of Health. We're here to serve you. How can we bring access to a life-saving vaccination? What would you like to discuss? And we went into amazing conversations with individuals. And it was just not only conversations about a vaccine. It was a conversation about everything. Can you also help me? I haven't received my Medicaid. I haven't received my Medicare card. Do you have job openings? So it turned into a real community involvement, but for them to see us. And it was novel, right? I got comments like, this must be so bad that we see you guys out here, because we have never seen outreach in person from the Department of Health ever to our doors. And you look at Trenton, we then moved to a partnership with Shiloh Baptist Church here in Trenton. Reverend Armstrong, working with him, we've vaccinated over 400 people with the events we've done with him. Where did we set up? At the old campus of Mercer Hospital. And when we got to that community, the community said to us, are you bringing back this hospital? Because we were abandoned. Our healthcare, when that hospital closed, this neighborhood has been abandoned. We have no primary care doctors. And it's that thinking of how can I positively go and do and take action to bring the service.
Thank you so much, Deputy Commissioner. That's exactly what we wanted to talk about. We are near the close of our time together. This has been so thrilling, and quite frankly, I know that we could talk forever. I though want to make certain that the types of things that we've seen and around setting policy through a lens of privilege don't happen again, the way in which we saw it happen at the beginning of COVID. I'd love to be able to ask the both of you to share with us in your one or two closing comments. Really, so what can organizations, what can community development sector, what are the kinds of questions that policymakers can ask in order to ensure that they are actually seeking and achieving more equitable outcomes?
Definitely. Every institution and every system has a responsibility to ask first, how is racism operating here? If you don't ask how racism is currently operating at baseline, then you don't design to intentionally disrupt it, okay? Two, every institution and every system must ask, what do I know about this community, or what do I know about this region or state? What is the story? What is the narrative? What are the lived experiences? Because solutions have to be born out of need, and innovation has to be born out of truth and authenticity. And then finally, we all need to work more upstream, because the more upstream we work, the more we focus on prevention. And we here at University Hospital have been talking about a prevention army. And what does that look like? That looks like community health workers. That looks like community integrated care models. It looks like our partnership with New Jersey Department of Health with the mobile vaccination units. It looks like going where community is and providing care in place-based settings that can then begin to dismantle and untangle the web of institutional systemic factors that have contributed to the inequities and disparities that we see.
Thank you, good doctor. Deputy Commissioner.
I think that as this crisis has magnified the disparities that exist. Yes, we can't divorce all of the structural racism built into a system that now has been magnified. Cannot let this crisis go past us when this disease becomes endemic without thinking we should never be here again. And what is it that we could do moving forward to intentionally change the outcomes for these communities? Why don't we have better access? And what can we do to bring that access and to bring good quality care to these individuals? And to know that you have to understand, as Dr. Purnell says, their entire ecosystem of what has brought them to this point. It's not just a free vaccine, right? That's a small band-aid of protection, but all of the things that need to be connected to that. It was about really thinking outside the box and trying to tear back and really be disruptive in the influence that we have when we are in a position to be able to do that, to really be working towards the betterment of public health and the services that we give to the state.
Thank you so much, Deputy Commissioner. Thank you to this fantastic panel. Ladies and gentlemen, trying to shrink the gaps in health outcomes differs from just trying to improve and promote public health overall. It's a complex objective that requires new thinking and new strategies for action. Take that with you and the great comments from our fantastic panel as you go forth to create a more equitable society for all. Thank you for joining us.